Um, Good afternoon, ladies and gentlemen. I first want to thank the organizers for inviting me here. I'm actually substituting a Finnish person, Tuula Pirttilä, a former great scientist and a neurologist, great person who died last spring for cancer. And she suggested me to be her substitute. I'm very grateful and proud of that. So thank you. So my topic is rehabilitative approach in dementia care. And what I'm going to touch in this presentation, first I'm going to define what I mean by rehabilitation, functioning and disability in dementia. I feel that it's much more than mobility and physical functioning, but I'll show you why. Then I want to point out that we have to evaluate the needs of the rehabilitation of the dementia patients and target the rehabilitation in order to be effective in dementia. Then I'm going to go through some evidence-based, some nice studies which have shown effectiveness in rehabilitation in dementia. And finally, I'm going to discuss a little bit about the problems and possibilities we have at the moment in dementia rehabilitation. First, what I mean by rehabilitation and disability in dementia. For me, rehabilitation in dementia is a process of assisting someone to improve, maintain, or functioning or delay disabilities. Often it's the last one in dementia. The aim in dementia, as in any elderly people, is to enhance autonomy, functioning, mastery, and well-being. And it's always a process of change in person and environment. It involves both patient and a caregiver, and that's a fundamental question so that we can make the rehabilitation effective. Rehabilitation in practice actually is, traditionally it has been thought that it's physiotherapy for older patients. And even in this respect, it's underused resource for patients with dementia. But I think that the whole concept needs a little bit rethinking among dementia patients. It's also cognitive rehabilitation, psychological and social rehabilitation. And it's much more than medical care or physiotherapy. It's a comprehensive approach in the care of dementia patients. And the caregiver, I want to stress, has a central role in interpreting patients' needs and wishes. What is functioning then? We all know that is ability to manage daily activities. It's dependent on personal capabilities, but also on environment. Dementia patient in her or his home environment is always more capable doing things than in a strange environment. It has dimensions of activities of daily living, instrumental activities of daily living, but also psychological dimensions, cognition, mood, mastery, well-being, as well as social dimensions like social activity, isolation, or loneliness. This is an old model by Nagy, who showed that disability is always a consequence of a disease. And I have modified this model according to how Alzheimer's disease develops disabilities. First, you have the pathology which causes physiological injuries, cognitive decline. Further on, it goes to functional limitations, executive functioning may decrease, and then finally to disability, meaning difficulties in ADL. But this whole process can be intervened by rehabilitation and adjustment coping abilities of the patient and the caregiver. So, how do we evaluate the needs of rehabilitation of the patient and target rehabilitation according to that? I have built up this kind of pyramid to show what kind of needs and risks the patients have at various stages of Alzheimer's disease. On the bottom, you can see mild cognitive impairment. The patients are very capable in ADL skills still, but they have risk of social isolation, depression, and further cognitive decline. And we have to target the rehabilitation to these dimensions. At the mild stage, they have often functional limitations, and they are at risk of frailty process, social isolation, cognitive decline, and further functional decline. At the moderate stage, you have to target differently the rehabilitation. They are already frail, they are at high risk of institutional care, they use home services, and they have often recurrent hospitalizations. They are at risk of functional decline, nursing home care, neuropsychiatric symptoms, and so we have to target the rehabilitation on these. At severe stage, many patients are already in nursing home, and there they have the risk of rigidity, mobility limitation, and getting bedridden. So we have to target rehabilitation on that. I want to point out that when we rehabilitate patient, we don't rehabilitate only the dementia patient, but also the caregiver and the whole family. So the needs and risks of dementia patient are highly intertwined with the whole family. They often have common problems and things that they both need, and we have to have a comprehensive approach on this whole thing. So now I'm going to go through some example of what kind of evidence there is about rehabilitation in dementia. I mostly go on physical activities and physical exercise, but there are many other approaches also which show effectiveness. The studies which have been investigating rehabilitation, the outcomes have been various. So I'm going to go through these studies according to what kind of the main outcomes are. First, I go for mobility and ADL functioning. Is there evidence that rehabilitation can improve that? Then on cognition, then on neuropsychiatric symptoms, and finally on patients and caregivers' quality of life. So you see my pyramid always on the right top, and you can see what stage this rehabilitation has been effective, the shown effectiveness has been. In this case, strength and endurance training have been examined on nursing home or institutionalized dementia patients. There are at least 13 studies of these strength training studies which have been randomized, and there have been mainly dementia patients in these studies, more than 1,000 patients, and 7 studies have shown that there's efficacy that these patients' walking speeds improves, ability to walk stairs, and their endurance is improved. 3 studies also show stronger aim point, that the efficacy on physical functioning, and 4 studies did not show any efficacy. There are also 3 studies which have had purely dementia patients in them. They are institutionalized, all of them. 2 studies show efficacy on mobility limitations, and 1 study from France show that they can also improve with intensive physical exercise 3 times a week for 1 year. You can improve Alzheimer patients' physical functioning. There are only 3 studies which have been conducted among home-dwelling dementia patients. None of them have tried to delay institutional care. 2 studies showed no efficacy, and 1 study showed improved physical functioning. All of these strength training, endurance training studies have limitations. They have low power, very low number of patients, which they are unable to show unless the differences are very big between the intervention and the control group. The interventions are not very well described in the studies. Their intensity and duration varies, plus the target groups are heterogeneous. But in general, the effect sizes in the rehabilitation studies on dementia patients are similar to seeing those in elderly people in rehabilitation studies. So there's no way that we can say that to be nihilistic among dementia patients and rehabilitation. This is our study in Finland, which is going on now from 2008. It's a randomized study where we randomized home-dwelling Alzheimer patients and their caregivers into 3 groups. One group is receiving twice a week home-based tailored exercise for 1 year. The other arm is receiving group-based exercise twice a week for 1 year, and one group serves as a control. I have here very preliminary results for that study. It shows that in all of these groups, the functioning is decreasing, it's declining. But in the rehabilitation groups, it declines slower than in the control group. Actually, in the home rehabilitation group is significantly better, the physical functioning, than in the control group at half a year. And in cognitive scale, it's both groups, the group and the home-based rehabilitation, are doing better than the control group at the half a year. So these are targeted on home-dwelling Alzheimer patients. Occupational therapy is also beneficial for dementia patients. It has been shown in a Dutch study that 10 home visits by OT to dementia patients, guiding patient and the caregiver to compensate the lost skills and to adjust to the situation, improves the dementia patient's physical functioning, and this was also cost effective. Then, my next outcome, cognition. Physical exercise also improves cognition. It has been shown in numerous studies among healthy elderly that exercise improves executive functioning, cognitive speed, delayed memory function. But also among those elderly patients who have already cognitive decline. In controlled trials, it seems that the effect sizes are similar in cognition as among healthy elderly. This was a nice study from Australia, published in JAMA a couple of years ago. 170 MCI patients were randomized to receive 6 months physical activity program for 2.5 hours a week versus control. They show that the cognition deteriorated slower in the intervention than in the control groups with various measures. We also conducted a study in Finland with lonely older people, showing that socially activating group rehabilitation can improve cognition among these people. We randomized 235 older people suffering from loneliness into intervention group and for control group. This lasted 3 months, once a week. And we could show that cognition improved according to ADAS-Cog scale significantly compared to the control. And the effect size is comparable to those seen in Alzheimer medication studies. And the participants included, besides cognitively intact elderly patients, also MCI and maybe 15% mild dementia patients. We had MMSE range from 19 on. Can we improve neuropsychiatric symptoms with rehabilitation? It was already shown in 203 that exercise may improve dementia patients' depression and also physical role functioning. It was a nice study conducted in the US. And finally, the quality of life. The tailored coordinated care by a case or care coordinator has been shown in so many studies already that we should really implement this kind of model in every care. At least 9 randomized studies where the intervention has included, for example, education, respite care, therapy, cognitive stimulation, emotional support for the dementia families, caregivers groups, and geriatric care. But the main thing in this model is the case coordinator. who coordinates and tailors the various support services for these families. They also all quite consistently show that the caregiver's burden, stress, and depression can be decreased with this model. Plus, 4 of these studies have shown that we are able to postpone institutional care of the dementia patients. We conducted such study in Finland a couple of years ago. We randomized 125 Alzheimer patients with mild and severe living with their spouse caregiver at home. We had a care coordinator, geriatrician, caregiver groups, exercise rehabilitation at patient's home, and the coordinator tailored services according to the wishes of the caregivers. The idea was to enhance the caregivers' problem-solving skills and their autonomy. It was family-centered intervention, guided with optimism, and it was resource-oriented. And we were able to postpone institutional care at 1.5 years, plus it showed that we could save costs and resources of the community. So, what is evidence-based rehabilitation at various stages of cognitive decline and dementia? At the MCI stage, you should use physical exercise and socialize in groups. At mild stage, you add occupational therapy. At moderate stage, you add care coordinator, geriatric expertise. And at the severe stage, you should use physical exercise still. We lack the family-centered care. We have to know what the patients and the caregivers really want and what they aim, because they are doing the work in the rehabilitation. And we also lack rehabilitation in respite and hospital care. Too much of this is seen. And we know from international studies that this kind of hospital care increases the risk of physical disability about 60 times. 60 times, it's a lot. What kind of elements are needed in effective rehabilitation? We have to be patient and family-centered. The family and the patient states the aims of the rehabilitation because they do the work. So in order them to commit to this, they have to state the aims. And we have to understand their needs and wishes. We have to enhance their problem-solving skills, empower them, support their autonomy and normal family life. We have to be optimistic and resource-oriented, and we have to support the whole family and take into account also the environment they are living in. So there are various points at the dementia that we can intervene with rehabilitation. We have to evaluate the need, make comprehensive assessment, and intervene with good evidence-based rehabilitation. Thank you for your attention.